All right, let's dive right into a super high-yield USMLE review on prediabetes. We're going to cut through the noise and focus on exactly what you need to know to nail these questions on your boards. So, picture this. You get a question stem about a 48-year-old patient. Their A1C is 6.1%. Right away, your brain screams prediabetes, right? But the USMLE isn't just going to ask you for the diagnosis. They want to know what's next. What are the real risks for this person, even if they never, ever progress to full-blown diabetes? That's what we're going to break down.
First things first, let's talk about nailing the diagnosis. To get any of these questions right, you absolutely have to have the numbers cold. So let's review the official ADA guidelines.
Let's frame this with a classic board-style question. What exactly are the criteria? Knowing these ranges is non-negotiable.
Okay, this table lays it all out perfectly. For prediabetes, you've got a fasting plasma glucose, or FPG, that's between 100 and 125, an A1C that's between 5.7 and 6.4%, or a 2-hour oral glucose tolerance test that lands between 140 and 199. You can see how these numbers are that critical middle ground, right? They're sitting right between normal and an official type 2 diabetes diagnosis. You gotta know these numbers by heart.
Let's really hammer this home. The A1C range, 5.7 to 6.4%. If you see a number in this window on your exam, ding, 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 it should be an immediate trigger for prediabetes.
And for the fasting plasma glucose, that magic number range is 100 to 125. Again, this is that key intermediate zone you absolutely have to recognize.
Okay, section 2. This is a huge, high-yield concept. The danger of prediabetes is not just about the risk of it turning into diabetes later. No, it is a significant risk factor all on its own. So how does that work exactly? Is prediabetes just a warning shot, a simple signpost on the road to diabetes, or is it an active player causing damage right here, right now? Understanding this is key.
And here's your answer, loud and clear. Look at this. A whopping 80% of the increased mortality risk in people with prediabetes comes from the prediabetes itself. It has nothing to do with whether they eventually get type 2 diabetes. That is a massive number.
And the research backs this up completely. The takeaway here is huge. You can't just tell your patient, hey, let's watch out so you don't get diabetes. The danger, the increased mortality risk, is happening now.
Now for the twist, because you know the boards love to test the nuances. Is this independent mortality risk the same for everyone? Does a 70-year-old with prediabetes have the same risk as a 30-year-old? Let's find out.
And here's the critical distinction. Studies show that this increased mortality risk is only statistically significant in younger and middle-aged adults, specifically from ages 20 to 54. For your patients over 54, the risk just wasn't significant after controlling for other factors. This is a game changer for how you think about risk.
All right, section 3. There's another connection here that you have to have on your radar for exam day, and it's the link to cancer, specifically pancreatic cancer.
This chart just spells it out. Compared to someone with normal blood sugar, a person with prediabetes has a 42% increased risk for pancreatic cancer, a 42% jump. And look what happens when they cross over into diabetes. The risk doubles. It's a clear dose-dependent relationship.
And let me be perfectly clear about this. This is not just because people with prediabetes are often also obese. The data shows that prediabetes, all by itself, is an independent risk factor. It's the glucose dysregulation, the chronic hyperinsulinemia, that's what's thought to be driving this.
Okay, so we know prediabetes is bad on its own, but what predicts who actually goes on to develop full-blown type 2 diabetes? Let's look at the biggest red flags. So the data shows a pretty clear hierarchy of risk factors. Yeah, having a higher fasting glucose, hypertension, and low HDL cholesterol are all part of the picture. But there is one factor that is, by far, the biggest driver of them all, and that's obesity. So why is obesity the #1 culprit? Well, it gets right to the heart of the pathophysiology. That excess body fat is literally promoting insulin resistance and causing the beta cells in the pancreas to get tired and dysfunctional. It's the engine that pushes a patient across the finish line from prediabetes to type 2 diabetes.
All right, let's bring it all home. Section 5, the high-yield review. If you're cramming the night before your exam, this is your final checklist. These are the absolute must-know facts.
First, the numbers. A1C, 5.7 to 6.4. Fasting glucose, 100 to 125. Burn those into your brain. Second, that independent mortality risk.
Remember, about 80% of the risk has nothing to do with getting diabetes. And third, that risk is really only significant in younger adults, aged 20 to 54. That's a huge point for prioritizing patients.
Fourth, don't forget the cancer link, a 42% increased risk of pancreatic cancer. And finally, number 5, the biggest driver of progression is obesity. It's the number one factor pushing people over the edge because of its direct hit on insulin resistance and beta cell function.